Okay, we will go ahead and get our seminar started for this week. So today our presenter is Emily Smith. Emily completed her bachelor's degree here at the University of Calgary with a specialization in biomechanics, and during her undergraduate program, she did some research projects on the influence of hockey stick properties on shot performance. And she's currently now a master's candidate in the biomedical engineering program and is a member of the bone imaging lab, where she's co-supervised by Dr. Stephen Boyd and Lauren Burt. Some of her current research interests include bone health in athletes as well as para-athletes and the use of medical imaging to evaluate bone microstructure. Some of her other interesting facts about her is that she was part of the Dinos field hockey program for 5 years. And this is as well as she played ringette and field hockey. And so this ignited some of her interests in sport related health. So thanks, Emily. We're excited to hear your presentation.
Awesome. Thank you so much. Is my mic working okay? Wonderful. Perfect. Thanks for the introduction. So to go along with that, my presentation today, I'm going to focus on the use of medical imaging technologies in understanding bone quality and risk of REDS in elite athletes. So to start off, I would like to discuss a little bit of important background information, beginning with some athlete bone info. So bone strength is a measure of bone mineral density and bone microarchitecture, where increased bone mineral density decreases the subsequent risk of fracture. Bone quality then is the combination of density, strength, and microarchitecture. Athletic populations generally tend to have stronger and denser bones than the general public, and this is in part due to the high external forces and impact loading from their sport and training, as well as the high internal forces from their muscles and joints. And although athletes do tend to have generally better bones, they're also at a higher risk of low energy availability. Now, low energy availability is when one's energy expenditure, including that from their sport, heavily outweighs their energy intake, leading to an imbalance in their energy. Athletes are then of high concern for LEA due to their consistent high caloric expenditure in their sport and training. Of some LEA risk factors, some important ones to note are a low BMD-Z score, which we'll touch on a little bit more in a minute here, a history of stress fractures, and primary and secondary amenorrhea in females. There are many negative impacts of LEA, particularly the impact on sports performance, physiological function, and general health, as well as a higher risk of osteoporosis and fracture. So LEA is the driving force in a syndrome known as relative energy deficiency in sport, or otherwise known as REDS. And REDS has since replaced in an expansion of the former female athlete triad. And the female athlete triad focused on that trifecta of a low bone mineral density, low energy availability, and menstrual dysfunction. And among the obvious, female athlete triad had some limitations, including the fact that it was restricted only to female athletes and that there was a heavy emphasis on that menstrual dysfunction. This led to a lot of difficulty in diagnosis and screening, and it missed over half of the athlete population. Thus, the expansion was born from the REDS model. The REDS conceptual model came about first in 2015 and has since been updated in late 2023, bringing around some important additions. So as I mentioned, relative energy deficiency in sport is the clinical syndrome that results from problematic low energy availability, where problematic can be either prolonged and or severe low energy availability. And as we can see, low energy availability is in the center of that circle, and all of these things kind of manifest in what is considered relative energy deficiency. Of all of those many issues, some to highlight include the problems with menstrual function consistent with that female athlete triad, endocrine and metabolic health problems among general health problems, performance decrements and issues in sports, as well as decrements in bone quality. And bone health is important in this sense because bone health is one of the objective measures of REDS, meaning that it can be screened as either a yes or no, rather than having some of the more subjective materials. And although bone health is important, especially to people from the bone lab like myself, it is not the only marker of REDS. And it's not the only objective marker of REDS either. Now, from this 2023 update in REDS came an updated clinical assessment tool as well. This clinical assessment tool, or the REDS-CAT2 as we call it, is a 3-step model, including step 1 being a screening process where we cast a broad net, assess a great number of athletes using population-specific questionnaires or interviews that are lower in sensitivity and specificity, and try to get as much information as we can on their potential REDS risk or concern before we move into step 2. And those athletes that are considered to be higher risk are often moved to step 2, which is the actual clinical screening process where we use the REDS-CAT2 to determine their risk severity. From step 2, those who are considered to be at high risk of REDS are then triaged into step 3 for the clinical diagnosis and visits with a practitioner for appropriate treatment. I'd like to focus a little bit on step 2, as this is what we used in this project to actually consider athletes as at risk of REDS or not. So the REDS-CAT2 is actually an Excel spreadsheet that is openly accessible and you can download from just by searching it up. And as we can see here on the left-hand side are the indicators, being it severe, primary, or secondary indicators. And these each have their own weighting system to determine the severity. And then on the right-hand side in the blue is where you would either answer yes or no for if that pertains to your particular athlete. And then where it says green right there with severity or risk status, that will change depending on how many risk factors an individual has and what type of risk factors they do have. So in particular, the severe primary indicators include primary amenorrhea, which is the failure to menstruate by age 15, and prolonged secondary amenorrhea, which is the absence of a menstrual cycle for 12 consecutive months. In males, it is that clinically low free or total testosterone. Primary indicators are 1 point less than the severe, but are still enough to consider someone as at risk of REDS. And this is secondary amenorrhea that is not prolonged. So this is the absence of 3 to 11 consecutive menstrual cycles, subclinically low testosterone, and then a low T3, prevalence of high risk bone stress injuries, which include a stress fracture at the femoral neck, sacrum, or pelvis, or a number of lower risk bone stress injuries, which would be radius, tibia, any other bone, I guess, other than those major ones. And then there's also that emphasis on that BMD-Z score of less than or equal to -1 at the lumbar spine, total hip, and femoral neck. And note that it also includes the decrease of BMD-Z score from prior testing, which I'll speak about later as well. Secondary indicators include oligomenorrhea, which is the absence of a regular cycle for less than 12 consecutive periods. And then there's also an emphasis more on those low risk stress fractures, as well as elevated cholesterol and a clinical diagnosis of anxiety or depression. And as I mentioned, all of these things together contribute to REDS risk. However, one that we focused on for this project was that BMD-Z score of less than or equal to -1, and seeing if this threshold can be applied to other imaging modalities or if it's DEXA specific. So DEXA stands for dual X-ray absorptiometry, and DEXA is the gold standard in BMD measurements. DEXA produces a 2D or aerial bone mineral density measurement, and we use it in most studies, in this study in particular, to look at that lumbar spine, femoral neck, and total hip. So a Z score is a normalized measurement that matches each individual to sex and age matched normative data. And this gives you an indication of where that individual or that athlete would lie in relation to other people that are just like them in terms of age and sex. So this gives us a deviation from, a score in terms of a deviation from the mean, so the mean being 0. In terms of osteoporosis, that deviation is considered anything less than -2 standard deviations. But for athletes, we do use a different threshold because their bones are considered to be stronger and denser. We use that threshold of -1 standard deviation instead. And although DEXA is the current gold standard, it does come with some inherent limitations. One of them is that DEXA is a 2D modality, and that it does have less ability to produce a volumetric or 3D bone mineral density measurement, which has us missing out on some of the geometry and microarchitecture that might be associated. Additionally, there tends to be a problem with the overestimation of areal bone mineral density in those larger bones, which we tend to see with athletes. So that could be a concern that larger bones tend to be overestimated, and we might be missing those who are actually at risk based on their DEXA. Additionally, that BMD Z-score of less than or equal to -1, although it is consistent in the IOC statement, it is debated whether or not it is appropriate for athletes and for all athletes at that. There is also some suggestion that it might be more appropriate to consider athletes by sport type in terms of like having impact sports and odd loaded sports be a different threshold than endurance or non-loaded sports. Luckily, we do have a way to measure our volumetric bone mineral density in an effective way. And that is by using high resolution peripheral quantitative computed tomography, or HR-pQCT. And HR-pQCT delivers a volumetric bone mineral density measurement by taking a scan at the distal radius and distal tibia. It produces a scan about the size and thickness of a hockey puck at each site. And we use this to visualize and analyze the microarchitecture and microstructure of the bone. From this HR-pQCT scan, we can then apply finite element analysis, which gives us an estimated bone strength and failure load of the bone, which is the mathematical prediction of when the bone would hypothetically break in a real world situation. So similar to a DEXA Z-score, we can produce an HR-pQCT Z-score by using normative.ca. And normative was developed in the Bone Lab, and it is a publicly available website that you are able to input, give it your standard morphological analysis from HR-pQCT, and it will produce a Z-score based on sex and site in the same way that a DEXA would. And now HR-pQCT allows us to measure different parts of the bone, including the cortical bone, which is the outer layer shown in green or in gray here, the trabecular bone shown in green, and the total bone, which is the cortical bone and trabecular bone together. Now, with all that in mind, my study was twofold, where we are looking at exploring the prevalence of all athletes with a low BMD Z-score via DEXA and via HR-pQCT. And then we're also looking at comparing bone quality between those athletes, between REDS risk in groups using HR-pQCT parameters. So for this study, we recruited 105 elite winter sport athletes through the through CSI Calgary. And then we had the data collection being a DEXA, where they came in for a full body DEXA, focused in on that left hip. And then we also had HR-pQCT, where they were scanned at the distal non-dominant radius and the left tibia to align with that left DEXA. Data analysis included the standard morphological analysis and finite element analysis, and then those Z-scores were produced using normative.ca. These results will be displayed in terms of prevalence and in terms of comparison by risk group. So just looking at our athletes by sport, we had a large number of our athletes come from long track speed skating, and another good number coming from cross country skiing, with this making up about 50% of our group. And the others included 13% in biathlon, 10% in figure skating, 6% in luge, 14% in cross country skiing, and a couple in just the other category. We had nearly equal numbers of male and female with an average age of around 24 years old. And our height and weights were appropriate as they would be for an athletic cohort and split between male and female. So first looking at our DEXA Z-scores, we saw that between males and females, males tended to have a lower BMD Z-score at the lumbar spine compared to females. And we also saw that more males than females had a low DEXA Z-score at any of our 3 sites. 3 sites included that total hip, femoral neck, and lumbar spine. And going back to that lumbar spine, we saw that of our 8 that were considered for a low DEXA Z-score, 7 of them came from that lumbar spine area. So the questions asked in this first aim were how many of our athletes had a low Z-score via DEXA, and then how many had a low Z-score via HR-pQCT, and how did those two compare? So first I'll walk you through kind of what we're going to be looking at, because there's a lot of them. On the left-hand side, this shows the site of the Z-score measurement, and that's going to correspond to the entire row. This wheel shows all of our 105 athletes. The slice pertains to the number of athletes with a low Z-score, and then this percentage is reflective of the slice. The color will represent the group that it is representing, I guess, red for all, pink for females, and blue for males. So first, we're going to be looking at low BMD Z-score via DEXA. And as we saw in that chart before, we had most of our low Z-score classifications coming from that lumbar spine area, with only a couple in the femoral neck and total hip for some of our male athletes. For the low total BMD, so total BMD is considered as the cortical bone and the trabecular bone together, measured via HR-pQCT. We saw that there were more athletes that had a low total BMD at the radius compared to the tibia, and that 20% more of our males had a low total BMD at the radius compared to our females. Moving on to our cortical BMD, so cortical is just that outside bone. We saw a higher prevalence in all of our athletes and almost equal numbers in males and females, seeing nearly 40 or over 40% of our athletes having that low cortical BMD Z-score at the radius, and over 30% having low cortical BMD at the tibia. Consistent with the total BMD, we saw that there was a greater prevalence at the radius compared to the tibia. Moving on to trabecular BMD, which is the last one by HR-pQCT here, that we have just that inner bone. We saw less than the cortical bone, kind of in line with what we saw with the total. And we see again that there was a higher prevalence at the radius than at the tibia, and that there was a larger difference between the radius and the tibia for the males. Lastly, we look at failure load, which was determined using the HR-pQCT and applying finite element analysis. We can see here that this was a lower prevalence. We saw, again, consistent that the radius was had more low failure load Z-scores, and that there was a higher prevalence in males than there were for females across the board. So just a couple of things to highlight here. Looking at the DEXA compared to the trabecular BMD in particular, for males, we saw that when we averaged the radius and the tibia, that we had an average prevalence of about 10% of males having low trabecular BMD compared to that low DEXA, which was also 10%. Looking at the females, we saw a prevalence of an average of 6%, which again was consistent with the DEXA, and this just shows that our trabecular BMD was most consistent with what the DEXA reported in terms of Z-score prevalence. Now we're going to move on to some box plots for which our Z-score is on the left-hand side, our site and modality is on the bottom, our DEXA is displayed as light blue, and our HR-pQCT as dark blue. DEXA reads femoral neck, lumbar spine, total hip, and then the HR-pQCT reads radius and then tibia. For HR-pQCT, we are only looking at total BMD because this is the most similar to the DEXA BMD. The threshold here is that -1 standard deviation from the mean, consistent with that REDS risk classification. So as we can see, plotting all of our athletes, we only have a couple that fall below that threshold for DEXA, as we saw, but then we have quite a few more that fall below the threshold for HR-pQCT using total BMD. This shows just those athletes with low DEXA BMD, and as we can see, most of them come from that spine, and we can see the one that doesn't is from the total hip over there. And if we look, all of these athletes are transposed across all of the modalities, and we can see that some of them, even though they do have that low lumbar spine, tend to have high radius and tibia HR-pQCT, and if not high, they're at least above that threshold. So in summary, from AIM-1, we discovered that there is a higher prevalence of HR-pQCT derived BMD Z-score, less than or equal to -1 standard deviation compared to that of DEXA. And when we do just use DEXA, the lumbar spine had a higher prevalence than both sites at the hip. We also saw that there was a relatively higher prevalence at the radius compared to the tibia, looking at all of those HR-pQCT parameters. We saw that there was an overall higher prevalence in males than females, and that cortical BMD was relatively low, and that we had that low Z-score for a good number of our athletes. What's interesting here is that 7 out of the 8 that had a low DEXA Z-score also had at least one low HR-pQCT Z-score, that being total, cortical, or trabecular. But we also, of the ones that did not have a low DEXA Z-score, so their DEXA is normal, they also, 51 of the 97 had at least one low HR-pQCT Z-score as well. So to conceptualize this, I apologize, the numbers are different, but these are the proper numbers. So what we're seeing here is that these ones with the normal DEXA, this is what we would expect, is that most of them would fall here. If you have a normal DEXA, that you would have a normal HR-pQCT. But what we're actually seeing is that a really large number of them who had a normal DEXA also had a low HR-pQCT. So this is making us wonder what's going on with athlete bone in terms of their HR-pQCT measurements. And then moving on to AIM-2, we look to compare the bone quality between REDS risk groups using HR-pQCT. So moving a little bit away from the Z-scores that we were just talking about and looking more at the actual HR-pQCT parameters. So in order to classify these athletes as at risk or not at risk of REDS, we did use that REDS-CAT2 tool, where we found that 45 of our males, 42 of our females were not at risk of REDS. However, we did have 5 males that were at risk. 5 males that were in the yellow risk, 11 females that were in the yellow risk, and then 2 females that were orange risk. We did not have any that were in the REDS risk, thankfully, but we used the yellow, orange, and red to combine together as an at-risk group to compare to our not at-risk group. So looking at the number of athletes that fell into the at-risk group by sport breakdown, we see that a large number of our biathletes, 36% of them, were considered at risk of REDS. And we also had 26% of our cross-country skiing athletes be considered at risk of REDS as well. Between figure skating, long track speed skating, and luge, we saw between 10 and 17% being at risk of REDS, whereas our ski cross and our other group did not see any fall into that at-risk category. We saw that we had more females than males be considered at risk of REDS. And we also, just an interesting thing to note is that our age of menarche in the at-risk group appeared to be higher than our not at-risk group, which is to be expected because primary amenorrhea is a primary indicator. And so if any of the female athletes did have age of menarche being 15 years of age or older, they were automatically placed in that at-risk group. So this is consistent with what we would expect. Just an interesting thing to note is that our contraceptive use, our hormonal contraceptive use for females was about 70% for the at-risk group and 70% for the not at-risk group. And those who were on hormonal contraceptive could not be considered for secondary amenorrhea because hormonal contraceptive negates the natural effects of the cycle. So you can't consider it as a REDS risk. Moving into those Z-scores again by REDS risk, this is the DEXA Z-scores. We saw that that lumbar spine Z-score was lower in the at-risk group compared to the not at-risk group, which is to be expected. And as we see again, that those with the low DEXA Z-score, a lot of them, 7 of the 8 came from that lumbar spine. And as we can see on the right-hand side, same thing, if you had a low DEXA Z-score, you were automatically placed in the at-risk group. That's why we have none in the not at-risk group. So if anybody is familiar with HR-pQCT, you're aware that there's a plethora of variables that we can go through and analyze. So we chose to break it down into looking at total BMD and failure load as our primary variables. Total BMD because it was most similar to DEXA, and failure load because it was able to be a proxy for estimated bone strength. And then of our secondary variables, I'm only going to speak about the ones that were significant or approaching significance, including cortical thickness and area, trabecular BMD, and bone volume fraction. A new type of box plot now. On the left-hand side, we've got our parameter, and the axis will change with the parameter. And then on the bottom, we have got our risk group, where our not at risk group is green, and our at-risk group is in red. So firstly, looking at that total BMD, we have our radius on the left and our tibia on the right. We can see that the at-risk group had significantly lower total BMD at only the tibia, and that it was not statistically different at the radius between groups. Moving on to failure load, we can see that the at-risk group was significantly lower in both the radius and the tibia compared to the not at-risk group for this variable. This just summarizes that we saw significant differences in both radius and tibia for failure load, but not in total BMD, for total BMD only at the tibia. These are a summary of the secondary outcome variables, where first we're looking at the cortical area, which did appear to be significantly different in both the radius and the tibia, showing that the at-risk group had lower cortical area at both of those sites. Similarly, we see that the at-risk group had lower cortical thickness at both the radius and the tibia. Whereas moving into the trabecular parameters, we see that with trabecular BMD, the at-risk group was approaching significance only in the tibia, but not in the radius. And similar to that, we did see that there was a difference between the at-risk group and the not at-risk group in the tibia for the bone volume fraction, as this is also a trabecular parameter, but there was no difference in the radius. Last thing I want to note is that we did also look at the total area, and the total area was not different between the two groups for either the radius or the tibia, which is good. And this means that the differences in parameters were not solely based on a size difference between the two groups. This just summarizes that our cortical parameters showed significant differences at both the radius and the tibia, whereas our trabecular parameters only showed significance or approaching significance at the tibia, and that there was no difference between the two in total. So to summarize, our primary variables, we saw that the failure load was lower in both the radius and tibia between the risk groups, or sorry, for the at-risk group. With the total BMD, we saw that it was lower in the at-risk group for only the tibia. And then in the secondary variables, we saw that cortical variables were lower in the at-risk group at both radius and the tibia as well, compared to the trabecular variables that were only lower in the at-risk group at the tibia. So in summary, this study has led us to question for AIM-1A whether Z-score threshold of less than or equal to -1 is too sensitive for the identification of low BMD in athletes, and if it can even be used for things like cortical bone, given that 40% of our athletes did show to have low cortical bone. And two, to ask in terms of REDS risk differences, if the tibia might be more reflective of true differences in bone quality. And we see that there are a couple parameters using HR-pQCT that might be more effective in evaluating such differences. Overall, we saw that elite athletes who are at risk of REDS did have lower bone quality than those who are not at risk of REDS, and that certain parameters from HR-pQCT can show that lower bone quality in REDS risk, and that might be more useful in the analysis than just using Z-score or Z-score alone. Future direction for this would include looking at a decrease in a DEXA Z-score, as this was recently listed in the updated IOC statement, where it listed a decrease in BMD Z-score from a baseline or from a previous to be as valid for that identification as just that -1. So potentially moving away from that solid -1 threshold and looking more individualistically towards a decrease. And then to further that, seeing if that is true in DEXA, if we can apply the same theory into HR-pQCT, and if so, should it be only total BMD, or if we could apply it to trabecular or cortical as well. I'd like to note that for our recruitment, we did not recruit athletes specifically based on REDS risk or based on REDS concern. In fact, none of these athletes were considered at risk of REDS. Most of them are competing at a national or international level, and they're otherwise healthy, training, eating well. And so the fact that we found 18 of our 105 elite winter sport athletes to be at risk of REDS is quite interesting. And we did see that there was a higher prevalence in females, which is not shocking considering the metrics used in the REDS-CAT2 tend to be a little bit more focused on females, whether or not that be intentional, but we saw more with the females. And we also did see 2 of our 105 athletes fall into that orange risk. Both of them were females as well. So this begs the question of if differences between sport types should be explored in terms of impact loading or endurance loading. And I'm going to say yes, they should be explored because if you remember, a good portion of our athletes that were in that at-risk group were from that biathlon and from that cross country, which are more endurance-based winter sports compared to ski cross and long track speed skating, which might be considered more impact loading. So this just shows all of our athletes who were at risk of REDS. You can see the ones in black are the ones that had a low Z score and were at risk of REDS. So this just shows that BMD Z score and a low bone parameters, I guess, in general, does not necessarily lead to your REDS diagnosis. And some that have REDS or are considered at risk of REDS are still at the very, very top of the all of these box plots. In the use of the REDS-CAT2, some of the limitations within our population, as I mentioned, is that nearly 70% of our females were using hormonal contraceptive, which does negate the ability to use secondary amenorrhea as a primary risk factor. So we might have been missing out on some athletes that are in fact having menstrual dysfunction or menstrual issues, but it's masked by the fact that they're using hormonal contraceptive. This isn't necessarily a limitation, but something interesting to note is that clinically low testosterone is considered a severe primary indicator for males. We had 0 that were clinically low in testosterone. We also had 0 that were subclinically low in testosterone. Even though a few of our athletes did have relatively low testosterone, they were still well above what would be considered clinically low. So just asking if that threshold is appropriate to athletes, appropriate to all athletes, as the literature around that appeared to be a little bit ambiguous. So yeah. And then moving into stress fractures, again, this is a good thing in general, but 0 of our 105 athletes had high risk stress fractures. Whereas if we were to apply this to summer sports, running and track and those type of sports, we might see a higher prevalence just because of the nature of the sport. And we only had 3 that had low bone stress or low risk bone stress injuries, which was a secondary indicator and not enough to consider them as at risk of REDS. We also did not have access, nor did we administer the eating disorder examination questionnaire, which is considered a primary indicator. So if these athletes would have completed that and ranked highly, that also could have contributed to their REDS risk. And lastly, going into a discussion of bone parameters, we saw really high prevalence of low cortical BMD in these athletes, which is consistent with the literature surrounding amenorrheic athletes and just athletes who are at risk of low energy availability in general. So not surprised by that, but wondering if that actually translates to just all athletes in general. And it was also interesting to see the difference in cortical and trabecular parameters between risk groups, seeing that trabecular parameters only seem to have differences at the tibia compared to both the radius and the tibia, like the cortical parameters did. Again, just to emphasize that between sport comparisons should be explored as there's limited information known about these winter sports and even less known about these winter sports in REDS risk. So future directions for this study include looking at that BMD change over time as that decrease in BMD Z score has recently been included in the IOC statement. We currently have 28 athletes that do have at least one follow-up, which is great. So hoping to get more of those in so that we can explore the change over time for them. We also want to see how REDS manifests in para-athletes. We currently have 29 para-athletes that have come in for a visit 1, and many of them have extreme variation in physical aid, whether they wear a wheelchair or whether they use a wheelchair or wear prosthetics or just are regularly mobile. And they also vary quite a bit in terms of their ability, whether they are quadriplegic or they're just missing a finger. So that would very much impact their skeletal structure and bone mineral density. And then putting 1 and 2 together, we would like to see how the bone mineral density changes over time in these para-athletes, which is especially interesting for those who might have a more recent injury, especially a spinal cord injury, and how it might be appropriate to, I guess, understand how their bone mineral density is going to decrease as a result of their injury, and if that is actually putting them at REDS risk or if that's just kind of natural progression. With that, I would like to share a little bit of the preliminary data that we have on our para-athletes. And I'm going to play a guessing game. Can you guess which one is the para-athlete? A, anybody? B and C. Okay, if you said A, you are correct. This person was born with a defect where their lower body did not form. They have never fully loaded or loaded their tibia at all, and they have used a wheelchair since birth. This person is yellow, REDS risk. However, this person is also a para hockey player. This person had a single leg amputation. So the tibia that we scanned is normally loaded. They're able to train, jump, run, walk, everything as an able-bodied person would. And they wear a prosthetic leg, which puts them at a green risk. However, this person on the right is a figure skater who, although they do not have a low BMD Z score, their tibial trabecular BMD, which the trabecular is green, their tibial trabecular BMD Z score is less than -1. So they are at green risk, but as we can see, their tibial structure is a little bit different from the one in the middle there. And with that, I would like to thank my supervisors and my lab mates and the bone imaging lab staff, as well as the Canadian Sport Institute of Calgary and the athletes for their participation. And I would be happy to take any questions now.
Awesome, thanks, Emily. So just to get a bit more participation from some of the undergrads that I know are in the seminar course, we're just going to allocate a few minutes to questions from that group. So do any of the undergrads have any questions? You know that you have a lot of interesting ideas and thoughts to contribute, so we'd love to hear it. Any brave souls?
I was in that undergrad course too, and I remember a lot of the time you're thinking it, and then you talk to your friends after, and they're also thinking it too. So just asking it is better.
Any questions?
You have to take it apart, they're great.
Okay, we'll come back. Think of some questions, and we'll come back to you guys. Any other questions to start us off? Venus?
Nice presentation. So I'm wondering about the treatment. So what did you suggest to the athletes who have like RED? And especially because it's at an age that when they need to build their bone. So I imagine that it would be hard to get them to build their bone if they are suffering from REDs.
Totally. So that's a great question. And I guess the protocol that we would have right now is because we do have that cooperation with the Canadian Sport Institute. This is a part of their annual package. So CSI goes through all of the collaboration and scheduling with their team lead, and the athletes come in as a regular appointment. We do the medical imaging, and then if the athletes are at risk of REDs, they do get flagged in our system. We then send that information to their team lead or their team physician, and then they will go through the appropriate treatment from there, because that also depends on, I guess, where they are in their Olympic cycle. Like if they're going to Paris next week, that might be a different plan of action than somebody who's just starting in the program and now has 4 years to build. So that would be out of our hands, I guess, and more in the hands of the physicians, but it would result in probably removal from sport, or at least monitoring from sport, and planning with a dietitian and nutritionist.
Any questions?
Mentioned wanting to look at more like by sport specific. I'm just wondering, you had a good breakdown by sport with REDS risk category. Have you looked at all with those lumbar, spine, T-scores by sport? Like more specifically, I'm wondering if that group are all from one sport type.
That is my next step. I know that 3 of them were from cross-country skiing and 3 were from biathlon. I'm not sure about the other ones. I think 1 was from long track speed skating and then 1 was from another, but the majority do come from those 2 sports that had the most risk.
Any questions?
Yeah. Seems to be like a lot of kind of interactions in all of this data, and I'm seeking just a bit of clarification. So if I remember it correctly, in the first part, it suggests when you did the male versus female analysis, it suggests that males typically have lower Z scores than the females do. But then when you get into the at-risk group, it's composed more of the females. So what's going on between the two measures there?
Sure. So that's actually a really good question with the expansion of the female athlete triad. So a big part of why REDS is being pushed to develop and pushed to include all athletes is they're realizing that REDS does manifest in males and that it's not specific to just females. However, as I mentioned, a lot of the severe risk factors are based in female reproduction and female factors, I guess. So I think that there may be a disconnect, especially in that testosterone piece. Like the only piece that they give that is a severe primary indicator or an indicator at all is that low testosterone. So I'm thinking that there is a disconnect in terms of like what we can use as a male as like a primary indicator. But that would be my guess, is that we don't have enough in the REDS-CAT2 or in screening and diagnosis that encompasses all of the ways that it manifests in males. As we're seeing, there's a lot more females that actually presented with REDS, although the males had higher prevalence of low Z score.
Could any of the discrepancy between the sort of the Z scores between the DEX and the HR-pQCT, could any of that discrepancy be attributed to the different populations used to calculate the Z score? Right? Like, so you've got the DEXA data. The DEXA Z scores is not from the same population as the Z. You're probably using the manufacturer.
Correct, yeah.
Do you know? Could that be? Could any of that be?
I can't speak for certain, but I think that that might contribute to it, especially, I guess I'm also not super familiar with what has been used to develop the normative Z scores, but I know that there's similar populations, but there might be more of a discrepancy between those two. So yeah, that is something to consider for sure.
Can I add to that?
Please.
So the normative population in Calgary, obviously we're thinking 20 to 29-year-olds. When we actually compare them to the NPAINS, which is the one that the DEXA manufacturer uses, we actually see no difference in that 20 to 29-year-olds. So we do have a fairly active population in Calgary, but we actually don't differ from the NPAINS.
Thanks.
Okay, so maybe no.
Maybe I would like that, but I don't.
Other questions? Michael?
I have another weird interaction. So again, in that first part with the Z scores, it was that the radius was more affected than the tibia. But then we get into the at-risk group and it completely flips. And then is that due to the sport type that composed the at-risk group, that they were these sports that would have done a lot of arm work, as opposed to like cross-country skiing and biathlon are going to put a lot of force through the radius relative to a long distance runner, like long track speed skaters.
Right. Yeah, exactly what you're saying. I would hypothesize that it would be based on the sport interactions, but also we don't know what all of these athletes are doing as like cross training. Maybe they're super active in off season and maybe they are doing the same type. But yeah, if I could hypothesize, it would be because of that loading in their sport. But that's something that I'm going to look into further, is the difference between the radius and the tibia in the Z scores compared to the actual parameters, because that was flipped.
Cool.
Just to kind of build off of that, and knowing very little about bone. So would you expect, like in terms of the interaction between RED-S and like the mechanical stimuli from like bone loading and potential increases in bone mineral density because of that, would you expect that the loading is protective then even in these like RED-S athletes? Like if you had a long distance runner, you'd expect that they would have some maintenance of their lower limb density, but then maybe loss in upper.
Exactly.
Okay.
So looking at, I guess, like tibia versus a radius control would be interesting to see for these athletes, because a lot of them it is lower body focus and lower body dominantly loaded. And we do think that the loading increases the trabecularization, but it might not be enough to increase the bone mineral density overall. So maybe that's why we see some of those differences. But yeah, looking at tibia versus radius would be an interesting thing to see.
Other questions? Lee?
Yeah, thanks for your presentation, Emily. I came in a little bit late, so I missed a bit, but I'm curious about the age at sport specialization. So figure skaters tend to specialize really early,
Right.
and are selected for the smaller size. Whereas I don't know much about cross country skiers or biathletes, but what age do they specialize in, knowing that physical activity participation during adolescence plays a huge role?
Right.
Are they more likely to have been multi-sport athletes before they got into these endurance sports? I just wondered if you had any data.
We do have data on that. We have the age of specialization and previous sports that they played. I think it's within the past couple of years, but it might be like previous sports that they played at a higher level. Have not looked into that yet, but that is definitely something that would be interesting to look at, especially for that consideration of, I guess, just specialization.
Yeah, and then were you surprised by the prevalence of REDS, considering like biathlon and cross country skiing isn't really lumped in that group of like aesthetic sports and of concern?
I was really surprised, honestly, that we had so many in biathlon and cross country skiing, especially compared to figure skating. I think a lot of people see figure skating and they just assume figure skating, gymnastics, all of those like weight class sports, or sorry, not weight class, but like weight more base sports are automatically, those ones are going to be the ones at risk of REDS. But we actually did see the higher prevalence in those endurance sports. So I was quite surprised, but thinking about the endurance demand of those sports, I'm not after considering it further, but would be interesting to see how, I guess, that expands into a greater population of sport.
Any questions, Venus? Yeah, Venus.
I'm just wondering what led. Is it caused by the athlete they are either not eating enough because they don't want to, I don't know, or they're eating but they're overtraining and so they're using all the energy with the training, or so you know?
Right. So the actual cause, I guess, of REDS would be that low energy availability, which doesn't necessarily have to be an intentional deficit, but it could just be that you're burning so much energy in training and you're trying to refuel and you're trying to be at maintenance. But if you're burning 5,000 calories a day, actually eating that much when you're spending most of your time training might be a challenge. So it's just it's either you're eating less than you're expending with the intention of slimming down or losing weight, or it is just you can't match that energy demand. So the intention doesn't have to be there, but it is the lower caloric intake compared to the expenditure. Does that answer your question?
But I thought that the diets of these athletes would be more controlled, like by the dietitian and people who would supervise them.
Sure. So I guess some of our athletes, they have like a nutrition log where they're asked to include the foods that they're eating and they have a weight scale or whatever. But if they are not properly educated, or if they are maybe underestimating, if they don't have access to that education or food scale or whatever, they might not be reporting exactly as they should. And not all sports are fortunate enough to have a dietitian be like, here's your meal plan, please eat this, although that would be ideal for most performance.
Online question?
Yeah, these are an online question. Go ahead, Robert.
Firstly, I enjoyed your presentation. I thought it was very thorough, so thank you for that. The trabecular bone, the measurement of the trabecular bone in any way you're doing it there, you take a single measurement, but do you know the variability of the measurement?
I'm sorry, could you repeat yourself? We missed the first part of that question for the volume.
Sorry, the trabecular bone measurement is a single measurement. I'm wondering, since trabecular bone is a metabolic tissue as well as a structural tissue, whether at the end of a heavy bout of exercise or at the end of breastfeeding, when a large amount of calcium is lost and it gets taken from the trabecular bone area, I'm wondering how variable that trabecular bone measurement might be, given that calcium can be sucked up very quickly. And do you have an idea of how variable it is?
That's a great question. My understanding was that it was variable. I don't know if it would be nearly as variable in this, I guess, population, as you mentioned, like the breastfeeding, but it is something that would need to be considered, but I don't know if it was necessarily accounted for, other than we do have the athletes' time of training per week and the demand per week. So maybe if we were to consider that and kind of, I guess, consider it in whether they came in at a high demand or a high training time versus like in their off season might be something to consider, but I'm not sure. Do you have any suggestions with that?
Well, for one thing, I was thinking that if you just take a single number, you can't actually see a change if you take a number today and then a number in a week's time after training or something, because you don't know what the distribution of those numbers are. You need to have a standard deviation. So I'm wondering whether doing repeat measures on a person so that you know if you're that a change is real or you weren't just within the the variability of the day. So taking repeat measures for an individual instead of just a single number, I think would be fairly essential if you wanted to see a change.
Perfect. Well, that's definitely something I'll consider and look into. Thank you for that.
Thank you.
Another online question?
Just another question. I just read it off the screen here. Is the normative data the same for males and females, or is it derived separately?
So a Z-score is age and sex match. So each individual will be paired with their appropriate sex and age range.
Other questions?
With the fact that your mean age was similar for males and females, and males mature later in terms of bone, do you think that maturity piece would have played in at any point?
That could be. Again, definitely something to consider. I think that, yeah, I'm not sure about that actually. That's a good point. Thank you.
Maybe I'll just comment on the question that came from the staff about the variability of bone. And so it's absolutely true. The trabecular bone is the most metabolically active bone, and it can change. But the time scale and magnitude of that change is the time scale is much longer, and the magnitude is much smaller than anything that would probably have an effect on your measurements. So even in the most intense stimulus for bone loss, lactation could be one, but the other, space flight, these bed rest, all of these are very intense stimulations for bone loss, would at most see a couple of % per month, maybe. And so a training session will have no measurable effect that we can see in a short period of time. Over 6 months or 12 months, for sure, we should be able to see things, but not in a short time. And just to clarify that.
Just to kind of add a kind of question related to the time course. In like you were talking about the potential for this new change in, I think it was the IOC, like how they distinguish people, and it's a change in the bone mineral density. In these individuals, if they've been training since presumably childhood, if they're elite athletes, would you expect that it like going based on a change would mask? Like, have they already plateaued essentially because they've been under these conditions for a long time?
Sure. That's a great question. And I guess the theory and the thought behind that is that these athletes, because they're doing such intense training and because they are engaging in this stimulus and they are still, I guess, relatively young, you would expect that they would still be increasing a little bit in terms of bone mineral density, or if anything, they would just be maintaining and it would be relatively stable. So a large or drastic decrease in bone mineral density in what you would assume to be otherwise healthy athletes would be more indicative of that that something's wrong there.
And I guess even if they're elite athletes, they could still increase their training intensity or that kind of thing.
Exactly.
Andrew?
What would be a concerning decrease?
That's a great question. I'm not sure. I'm certain that they do have it somewhere in the actual statement, but I know that like the blanket statement just says a decrease. So something to definitely consider. I'm not sure if it's 1% or 5% or
second. You can just, if you use two of the exact same dexes in different locations, you
get
different numbers.
I'm sure it would have to be site matched as well. Yeah, so like lumbar spine to lumbar spine, but yeah, I'm not sure what that % decrease would be.
Another online question?
Another question say, will bone outcome measures related to BMI or percent body fat?
Sorry?
The bone measured outcome related to BMI or percent body fat?
I would say not enough that it was, I guess, related, but I didn't necessarily look at the correlations of BMI specific to bone mineral density, but we do know that BMI is not necessarily an appropriate for measure of mass and percent body fat in athletes because it doesn't account for muscle mass. So looking into more like that lean mass or I guess lean mass, we do have information on lean mass and total body mass, but looking at lean mass compared to bone mineral density might be something to look into.
Just to kind of add to that, so is like outside of your study, is it common for people to have like a healthy body fat percentage, but to have REDs or like to have some of these like a decrease in bone mineral density as a result of low energy availability?
Sure, yeah. So it would not be specific to, I guess, one body shape or one body type. I think in the athlete world, we kind of assume that those who are leaner would be the ones who are more at risk. But like I said, there's lots of factors that contribute to REDs. So somebody that had that their age of menarche was 16, they would still be at REDs even if their BMI was like technically considered them obese. They would still be at risk of REDs. Otherwise, same kind of thing. If somebody is on like, I guess had more, had a higher BMI, they could still be at risk of REDs and still be decreasing in that bone mineral density. And that's another reason why it would be important to look at that in terms of decrease instead of just that baseline. But I'm not sure in terms of like the average population, what the REDs prevalence would be.
Yeah, cool. Any other questions? Last question? No? Awesome. Well, we'll thank our speaker, Emily,
Awesome.
again.
Thank you so much.